Okay, good afternoon. I think we're starting directly on time. My name is Greg Perry. I'm the Assistant Director General of the IFPMA, which is the organization that represents innovative biopharmaceutical companies. I have the pleasure to moderate this session this afternoon. We had a session last year, which I know a number of you were at, also for access to medicines, where the conclusions were that to deal with access to medicines, it required a holistic approach and an all-stakeholder engagement. And what we've done this year is build on from last year's session and to look at access to medicines and the role of partnerships in achieving the access to medicines objective. And I'd like to start off with just one quote, and it's from Dr. Tedros. He states, "Without partnerships, we cannot really move forward." And the intention of all the partnerships is, of course, to move forward towards that access intention. So today we've brought together a series of leaders from different partnerships, different organizations with different business models, some looking at innovation, many looking at access, some looking at NTDs, others looking at NCDs, others looking at treatments, and others looking at the whole supply chain and health structure. And the idea of today's discussion is to open up a debate and understanding of what the role of these partnerships are, how there is a need for different partnerships in different areas, and looking at the various impact that they're having in the access to medicines and innovation fields as well, where there is an overlap. My intention is to have an interactive discussion with the panel, and hopefully at the end, depending on how much and how interactive it is, hopefully to have a interactive session with yourselves, which is a question and answer session at the end of around 20 minutes. So my role then now is simply to introduce the panel, which is Dr. Carrie Adams, who's the CEO of UICC, Ms. Toko Elefik, who is the Director of United to Combat NTDs, Martin Bernhardt, who is today here as Chair of the Steering Committee of Access Accelerated, Dr. Katerina Burma, who is the CEO of FINE, and Dr. Manika Balasengaram, who is the ED of GARD-P. But to kick off today's session, I'm very pleased to invite Dr. Eva Njenja, who is the chair of the NCD Alliance, to give us the keynote speech. Thank you very much.
So, good afternoon. Thank you, Greg, for inviting me to this meeting and to this session. I'm really grateful that IFPMA thought and saw it wise to include a civil society from Africa to come and share how we think strategic partnership can move or can help us achieve the SDGs and also get to our UHC by 2030. I work in a society in Kenya that houses so many other associations, and we call it the NCD Alliance Kenya. That is our capital city. We have a lot of, we call them matatus, these vehicles that carry, commute various routes in the city. And amongst those routes, you also see motorbikes. We call them border. Now, the reason why I showed this is one of the NCDs we are struggling with, and which is really major in Kenya, is injuries from this kind of traffic and transport. So just, it was just something to let you know, but that's not all there is about our NCDs in Kenya. So who are we in NCD, in the NCD Alliance Kenya? We are one society that envisions seeing an NCD-free Kenya. That's our vision. Possible? Yeah, is it just a dream? No, I think we do have hopes, and we're already making some dents on the NCDs in Kenya. Our mission is also to be the lead membership organization in Kenya on all matters pertaining to NCD strategic pillars. We have our advocacy where we have capacity building, knowledge and management, meaningful engagement of people living with NCDs, and resource mobilization. Those are our 4 strategic pillars. Now, the reason why I said that we do hope we can work, we have many partners. At us, at the NCD Alliance, we have over 33 associations made of various specialists like, dealing with the various NCDs. And most importantly, we have quite a number of groups led by people living with NCDs. We have Kenya Defeat Diabetes Association, purely made of people living with diabetes. We have Stroke Association. We have people with epilepsy. We have Down syndrome groups. We have Med Hearts. We have all these groups which are strongly led by people living with NCDs. And we put this at the center of our society because of what we think that any policy, and one of my members of parliament here who is very keen and very active in our health, parliamentary health committee, she's there, she knows that if we are trying to keep our people with NCDs first, at the center of whatever it is, the policies, and I was talking to her that we need to really move towards that. Now, what kind of partnerships? I'm trying to show you that partnerships can actually push us quite forward and we can help us achieve our goals. Our partnerships usually energize and synergize. We reflect on our country's priorities. This is one of our partners, and I think the thing is, I think I'm allowed to say that one of the pharma that partners very strongly with the Kenyan government is an insulin-producing company, the Novo Nordisk, whom we are trying to push to become the Access Accelerated because of the work they already are doing. These are the people who have come to us as an NCD Alliance and as Kenyans and wanted to know what are our priority areas. And this is what we are talking about, strategic partnerships. People who can help us share, find solutions and help us sustain whatever activity we start. And that way also we have include the people who really will implement whatever projects that we are starting. The Ministry of Health partners with the NCD Alliance Kenya, and that's one of the things. We are an advocacy group, but we partner in a very clever way. We will hold them accountable in any policy they bring forward, but we also know that someone just said now that health is politics, and we do know in the previous session we've come from, we do know that if you do not work with your government, whether you're in the civil society or whether you're in whatever NGO, or whether you're private sector, if you don't partner with the government that makes policy, then nothing will move. So we have cleverly partnered with the Ministry of Health, and we have other centers. DMI means Diabetes Management and Information Center. We have then pharma and persons living with NCDs. Just partnering with some of this, we have found one way of getting people living with NCDs, especially type 1 diabetes, get insulin. And this is a project that was started in 2013, 6 years ago. And we have found that the ministry, having been part and parcel of this, has actually taken this on. And I think even with the pharma exiting in 2020, we will still have this program going on. We will be able to sustain it. So this is the kind of strategic partnerships we are talking about, Greg, that if we partner cleverly with the pharma, you will be able to get projects that will be sustainable. Children living with type 1 diabetes need insulin, and I think without that project, where we started with this particular farmer, a number of the 2,000 children in this project, I am almost 100% sure 50% of them will not be alive. So I think that is a strategic partnership that has seen children's lives saved, and also we have found ways now as a civil society and also with the Ministry of Health, finding ways to make sure that this project is sustainable and to move on. So in that way, we embrace our partners and we aim to succeed. Now, this little child, I will tell you about her. She will tell you exactly why partnerships work. And I think before, the idea is I was supposed to use 5 slides so that I can help all the panelists say a few things. But I needed to show you, this is a child with type 1 diabetes, and she's got a poem that she's going to, hopefully you'll be able to hear it. And that's one of the centers that, the activities that we had for that particular child. What innovations do we have in our NCD Alliance that really will help us achieve our SDG 3 and SDG 17? We have this. Kenya Defeat Diabetes, they have an app. Someone said earlier that a number of African countries, and Kenya included, we have one of the best mobile services. I think over 80% of our Kenyans own mobile phones. Now, the patients with diabetes have this association. They negotiate for its members through an app, whereby they are able to pass the word to every member who is a diabetic as to which farmer or where they can get the best medicine, best quality, and of course, affordable. So that now goes around the whole country for all people living with NCDs. They have groups in several counties. In Kenya, something maybe that I don't know whether is common or is current in most countries. We have devolved health. We have 47 counties, and every county has a minister of health. They have their own chief health executives. But this association of people living with type 2 diabetes have support groups in over half of in fact, 27 counties. And through those members, they have those apps whereby they're able to communicate. And I think in TICAD, I was talking to one of the World Bank directors who is interested in trying to help this to be rolled out in the rest of Africa. Because that's one way of making sure that people know and have the information that they need about the medication that they are using, the quality, and of course, because they are the NCD Alliance, we make sure we give them the kind of capacity that they need in the way of giving them education and getting diabetes educators talk to them, getting the diabetes specialists talk to them, and giving them the information that they need to empower each other. Now, we have other platforms, like what's called daktariafrica.com, a platform where you have e-consultations, and that reduces the travel costs. We are trying to see how will we be able to achieve UHC. One, by reducing the cost. The patients don't have to travel to the cities. Then we have another MTBA mobile service that saves for future medical funds. We have, my DAWA means my medicine, an e-pharmacy. Mjari, I don't know whether Dr. Gideji is here from AMLEF. This is a tool that's collecting data and feeding it to a web-based database later. And this is going to help, especially as we train people, community health workers, and we train all the other health workers, then they collect data for us. We have a project that we are trying to start whereby we have quite a number of partners, and where we are looking at diabetes, hypertension, cancer of the breast, cancer of the cervix, cancer of the prostate, and all this we are looking, starting from creating awareness, diagnosis, treatment, palliative care, and rehabilitation, and then research. With that, we are able to collect all that data, and this is going to end up informing policy. Because again, without data, you cannot actually make any policies that will stand the test of time. And we have another one. So you can see there are several innovations that are already going on. And we are talking about innovations to help us access good and affordable medicine, and also this in its own way will help us achieve the SDGs. Now, partnerships again, we partner with pharma to educate children. These are all children with type 1 diabetes, where we take them for camps. We educate them. We get specialists in diabetes. We have specialists in diabetes education, nutritionists, and we take them either out of the cities and give them 3 days of creating awareness and also empowering them to be able to live with the type 1 diabetes. So why am I showing all this? Because we wouldn't be able to do this without partners in the pharma and partners from other health bodies who are interested in the same kind of work that we do. So this is what I'm saying, partners do count and they help us. So this is one way, in a very simple way. Greg, I told you I'll have very few slides. This child, and I'm hoping I'll be able to for you to listen to this, because it speaks everything I wanted to talk about today. I'm hoping I can be able to.
My name is Jacqueline Wanjiko. I'm here with my mom and my brother, and I'm ready and happy to present to you a poem entitled Because You Care. I was growing up normally, like most of the children in our village. Yes, we had the common challenges here and there. I was still hopeful. I cherished my childhood dreams. I want to be this, I want to be that. The future was gleaming with great hope. No one prepared us for any eventuality, at least me. It happened very fast. There was no way to understand. Within 2 weeks, the eye we knew became very sick, presenting with unquenchable thirst, rapid weight loss, frequent urination, and even more embarrassing, bedwetting. Who was supposed to explain all this? Then came the doctor's report. He explained it was the sugar disease, or the disease of the sugar. That's all I grasped, but still it didn't make any sense to me. Mom and I cried, and the difference was I cried because she did. Still I couldn't understand. If it all ended here, really there was no hope. It takes a village to raise a child, so they say in Africa. The news spread, and everyone came out to their numbers. Always heard contraptions. This ended to hospital bed, worse than before. In the spirit of picking up the pieces and move on, we learned of the program supporting children living with diabetes type 1. Who was going to restore our hope? It is an open secret. Things could have been worse now, but someone thought about the future with a child like me in mind. The program has not only changed my life with diabetes, but our families as well. Thanks to Novo Nordisk, DMI, and the other CDIC partners. Yes, there is hope, because you all care.
Yep, that's what I want you to think about. That child is representing what partnerships can do. As she says, there is hope for children with type 1 diabetes. There is hope for people with NCDs. There is hope for people with other diseases, because the farmer and all the other partners, you care enough to support and to collaborate with the people who are doing all this great work in Kenya. So that's the quote I'll leave you with. Our task is not to fix the blame for the past, but to fix the cause for the future. And partnerships, please, in strategic partnerships, we will do this. Thank you very much. I think now, Greg, we can open the panel to the other discussions.
Eva, thank you very much, and of course, bring it right down to earth on the ground. And your own organization, as we can see, is focusing on very on-the-ground issues. You mentioned negotiations and priority setting for treatments, platforms for e-consultations, mobile phone services, e-pharmacy applications, and the provision of data, and the importance of those partnerships. So Thank you for that. I'd like now to open to the panel. We're going to have a first round of discussions around the partnership models that each have, and then later we're going to sort of zoom out on the greater access to medicines discussion. So I start off with Carrie. Carrie, your organization, the UICC, states that it unites and supports the cancer community to reduce the global cancer burden, to promote greater equity, which is very important, and to ensure that cancer control continues to be a priority in the World Health and Development Agenda. Because you've been one of the most vocal groups, certainly in the Geneva area, on the issues of NCDs and obviously cancer in particular. What is the key aspect of your partnership? What is it that makes it successful, and what do you think that makes it particularly unique?
Thank you, Greg. And Eva, thank you very much. That was a wonderful presentation. That girl was wonderful. Please say thank you to her. Let me start off by saying that I think as an organisation, first of all, the Union for International Cancer Control, at its very heart, wants to work in partnership. We're a small team, but we're a big community. So we need to work with others in order to have the impact that we want to achieve. And by reading out our purpose statement there, we have a lot to achieve. We want to maintain cancer and NCDs in the global health and development agenda. We want to address the issue of inequity around the world, and that's not just north-south, that's even within countries where you have marginalised populations. And we also want to unite the community around the objective, even though we have different views and perspectives on taking things forward. So what I'd like to do is just talk about how does that manifest itself in our actions. And I'll talk about theory and practice. And I'll draw my examples from the UICC community and what we do, but there are hundreds of examples of good partnership models which exist within the Union for International Cancer Control's membership, which is over 1,200 organizations in 170 countries, and within the NCD Alliance community as well. And I'll mention the NCD Alliance as an example of a typology of partnership, which I think is one which works very well. So a couple of years ago, UICC worked with an organisation called the Partnership Initiative to look at how we could educate our members on how you could make a partnership work successfully, whether it's a partnership across NGOs, with the private sector, with governments, or all of them. And we came up with a booklet which is available on our website, and you can draw down, which looked at 4 different types of partnership, going from an easier one to a more complicated one. But the important thing is it set out that if you are trying to achieve an objective, you need to make sure that the partnership you create and you hopefully sustain is the right structure in order to allow the partners to feel they're successful in the delivery of that objective. There is not one model which is appropriate. So I'm going to cover 3 of them and give examples of why they work. So the first one is really a simple one-to-one relationship. That's where an NGO, for example, works with the pharma company or a technology company, where they combine their uniqueness, their assets that are complementary to make something happen. And these tend to be quite simple to create, but they tend to be shorter term. They're not sustainable because they're on a subject which is important to both at that moment. An example would be UICC working with Pfizer on Spark grants, which are grants that we make available to organizations around the world who focus on advanced breast cancer. And how do we mobilize funding into that community with education and training and give them a platform so they can argue for more attention from governments within their own country. So there's an example of 2 organizations working on a common theme. And to give you a non-pharma example, we work with Lombard Odier, which is a private bank in Geneva, where we link the wealth of individuals into different ways that they can have an impact in cancer globally, and not just in research, where most wealthy people think that's where we need to make breakthroughs. It's not true. The inequity issues means that the things that we know work are not distributed evenly around the world. And by redeploying their wealth, we can address those gaps around the world by helping people in low and income countries, for example, have the funding they require to do the work which is so important based on what we know works. The second one, which is a little bit more complicated, is where we're looking for combining for innovation. And I will use the NCD Alliance as a classic example of that. When UICC was approached by the International Diabetes Federation in 2009, we thought this had a lifetime of maybe 5 years, maybe 6 years, until the end of the MDGs. And it would roll off at that point, with success being that we had cancer and the other NCDs in the replacement to the MDGs. at no point did we think in those first couple of years I'd be sitting beside you and sitting beside another 70-odd organisations around the world who had embraced the concept that the siloed diseases could work together on common risk factors, on palliative care, on improvements in primary health care. So the ambition has been held across a multitude of organisations, working with industry, working with governments to make something happen where you can be as innovative as you just presented, because you have different people from different backgrounds and different sectors. So that's a second type of grouping, and it can be an informal alliance or a formal one, but it brings together people with a common ambition. The third one, which is even more complicated, involves a number of challenges like conflict of interest, brings in groups from different sectors, is when you're trying to do something completely transformative, where you know there's an issue that needs to be resolved, but it is very complicated and most people would run away from it. And my example here would be the City Cancer Challenge, which came about through discussions some 3 years ago, where we could see that 50% of the world's population were in cities. It would be over 65% by 2050. And in order to solve the problem of cancer, wouldn't it be a great idea if we improved the ability of cities around the world to address cancer treatment and care? Now, the only way we could do that was working with all sectors, the government, the state, the city government, the stakeholders in the cities, the hospitals, the patient groups, civil society, work with the technology providers like Varian, Electa and Accuray, the pharma industry, the diagnostic industry, the nursing association. I can go on and on and on. Just the thought of bringing that community together to focus attention on cities in a sustainable long-term way with a new organisation created with its own new board, which is multi-sectoral, demanded a lot of work from a lot of people. But in January this year, we launched the foundation, which is achieving that very objective, working cohesively, managing conflict of interest, helping cities around the world to improve cancer treatment and care. Now, each one of those models of partnership are very, very different. And I would encourage anyone who wants to work in partnership with others to address a problem in health, that part of the challenge is you have to be innovative about the way the partnerships are formed. And if you are aware that you can give away power, but achieve the objective, then I think you're in a better position to make a difference in any health issue you particularly want to address.
Yeah. Look, thanks for that. And I really like the way that you divided those three partnership models up. I think that's, I think a lot of people can reflect on that. And I also like the idea that you've identified, if I got this right, you know, the sustainability of a partnership, breaking down the solos, and I think in your third one, that range of partnerships. But the other thing you mentioned was inequity. And the need, you know, that we've got to address the fact that, you know, that resources are not properly distributed. Can I just focus a little bit on that one, and how do you see your role in dealing with that particular issue?
Sure. So inequity is something which I think most people associate with the difference between high income, middle income and low income. That's a major issue. And what we do through that is we make sure that UICC's members believe that they are part of a community which is sharing best practice and can support each other. So we have lots of our organizations that have competencies in one area where they can share their knowledge and understanding by teaming up or partnering or twinning with other organizations. And then we create platforms where sharing is the ultimate ambition. So World Cancer Day is about sharing best practice and ideas across communities. World Cancer Congress is bringing together great ideas and sharing them across the communities. And where we do see major advances in our community over the last 5 years is that we are seeing organizations reach out to others saying, we need help. Now, part of the partnership approach is to recognize that we can all support each other, but it needs someone to say, I need help. I would like someone to help me to do this thing. So by creating platforms of exchange, I think we can address inequity over time, but it needs to be driven by those who require the help in the first instance.
Okay, thanks, Cara. I think that's really good to move over actually to Toko, because I'm actually going to introduce you as representing 1 billion people. And there's a figure that I think that really needs to get across. And I'm going to let you explain that and explain how your partnership, which involves a number of different sectors, is able to achieve the certain you know, your objectives around reaching the 1 billion, but I'll let you explain that.
So I can definitely talk about the 1 billion, but to represent 1 billion people, that is definitely something that nobody can carry over their shoulders. But thank you for trying. So I work for a partnership called Uniting to Combat Neglected Tropical Diseases. This is a partnership which was set up in 2012, and we call it a partnership of the willing. Partners that were brought together or came together, united by one single goal, which is to end the suffering caused by a group of diseases that are called neglected tropical diseases. So the World Health Organization classifies these diseases. So we do often get asked the question, so what are neglected tropical diseases? Who decides what are neglected tropical diseases? And thankfully, that's one thing that as a partnership we don't have to do. WHO with member states decides what diseases are neglected tropical diseases. And as the name suggests, these are diseases that really hardly get any global attention, and they affect a staggering number of people. Over 1 billion people, that's over, you're talking about 1 in 7 of the world's population suffering from some of the most gross and horrible diseases. If you imagine that in the 21st century, you can have a human being having a worm coming out of their leg. Mankind has been able to do so much, but just when it comes to these diseases, where you've got children with worms, women being blinded by a bacterial infection and unable to work, it's just really, I think, there is no excuse. So you can imagine a group of partners on the back of WHO setting out and writing out this roadmap at the end of 2011, setting out what could be achieved with those diseases. At the time, there were 17 of them. And WHO gave out a very clear direction and a map of what could be achieved, which of those diseases could be eliminated, which of them could be controlled, and which could be eradicated. And somebody describes it to me as somebody who came in intending to make a stew. All they had was a fire and a pot. And then partners sat around the table and said, what is it that I can contribute to this stew? And somebody said, I've got a carrot, I've got salt. Somebody said, I've got black pepper. Somebody said, I've got, I can contribute parsley, or I can contribute some meat. And somebody said, I can put in some potatoes. So, but altogether, these partners came together and ended up with this incredible partnership of people and organizations made up of industry partners, over 80 non-governmental organizations, government donors, a really unique partnership, I think, in global health, people driven by a common purpose. And if I can tell you what this partnership has been achieved, it is staggering, the same way as the numbers of people that are affected. So of course the partnership came in, there was already work happening on neglected tropical diseases, but not at this scale. So at that meeting in London, industry contributed or committed to donate 17 billion worth of medicines for these diseases. That's a huge number. And it equates to over 1 billion treatments being donated by pharmaceutical companies a year. And if you look at the WHO reports, you will see that in 2015, 2016, 2017, and 2018, 1 billion people have been reached with at least one treatment for these diseases. That, I think, is fantastic for a program to deliver that on the back of medicines that are donated. And I know we can come to talk about this because I've had so many conversations here in at least some of the sessions that I've gone to. Is donation sustainable? Why would you do that? Why would anybody do that? But I will go back to what I said earlier. These are diseases that affect the poorest people. These are diseases of poverty, diseases where people have a multitude of problems to deal with. One individual grappling with lack of access to water, lack of a clean toilet, lack of income, lack of absolutely just the basic necessities of life. And on top of that, you pile on disease. And so you can see how it is a moral imperative that we can help individuals like that. So I'm particularly proud to work for a partnership that has put at its center supporting and increasing access to people that are at the very bottom of any poverty index.
Toko, I mean, there's that example of that sort of third type of partnership that Carrie was mentioning. And I just want to pick up on that donations thing, because when we had the discussion beforehand, there's a lot of discussion when we're talking about access to treatments that donations are a thing of the past, yeah? And we should be looking at what I think you're saying is that, in certain key circumstances, particularly maybe where there is, not big population levels, if we're looking at individual entities, this is the only way forward and the way forward.
I think definitely donations have a place. And I think for neglected tropical diseases, that's definitely a group of diseases where I feel that a donation program has had a role. The question is it sustainable? Is it something that should be there in 10 years or in 15 years? I don't think so. But is it right for today? Absolutely. And why am I saying that? If you look at the numbers of people, so if you look at the statistics, the numbers of people who require treatment for neglected tropical diseases in, say, 2012 were 2 billion. The numbers of people that require treatment for entities now is just around 1.5 billion. So you can see that the numbers of people that have required treatment is actually going down, and it will continue to go down. So what we're talking about is really helping the poorest countries to reduce the burden to a point where it is manageable. So we're talking about public health and eliminating of a public health problem. For the poorest countries, who is to know that when those countries reach potentially middle income status, because they've been able to improve the lives of the poorest people, that those countries may be in a position 5 years, 10 years down the line to be able to procure some of those medicines for themselves. But now we're talking about reductions in the numbers of people that require the medicines. That's a huge contribution. And I think if that contribution works to support the individual, works to support the communities, works to support the countries, I think that's a fantastic thing to do. But also it's helping the countries to develop financially to a point where they're able to even do much more. So I think, yes, I would say that there's definitely room for a donation, and that donation, I think, for me, is justified for these neglected tropical diseases, but potentially not for everything. But it's not something that I will sit here and promote that it should be here perpetually. I think we can really start thinking about what else after drug donations, what is the alternative? And I know that some of our partners are already thinking about this conversation.
Okay, thank you. I turn over to Martin now, who is the chair of the steering committee of Access Accelerated, which is an initiative of over 20 pharmaceutical companies working together in the field of NCDs. In addition, Martin works for Sanofi and has recently been involved in an interesting NTD initiative and partnership, which we might come back to later. But Marta, you've explained before that to you Access Accelerated is a catalytic initiative. Maybe you can explain that and how it sort of fits into the sort of ideas and needs that the patients and communities are needing.
Thank you, Greg, and I will try to explain why Access Accelerated is a catalytic model. First, chair of the steering committee, what does that mean? You can imagine a big table with 24 representatives of pharma companies, which are usually competitors, and we try to work together. We work together to define the way forward to combat NCDs, non-communicable diseases. Not obvious. We have some experience working together in the field of neglected tropical diseases, or TB, some other fields, R&D sometimes. For that type of response, that's really the first time that 24 companies work together to find new solutions. I just make a step back, and so 2 weeks ago there was in Lyon as a big global fund replenishment conference, and the achieved goal was to get 14 billion to fight against HIV/AIDS, TB, and malaria over 3 years, and that is 1/3 of the sum which is needed if we want to be on track on those 3 diseases. For NCDs, it has been estimated that it would be trillion, and there is no such fund. There is nothing like the Global Fund for NCDs. If you consider healthcare systems, our history is that healthcare systems have been built to fight against infectious diseases. And that's definitely the case in most of the developing countries. So what do we do with that? And considering that NCDs is already the biggest killer in middle-income countries, and will soon be also the first cause of premature mortality in lower-income countries. So there is a response to bring. And what can pharma companies do on that? We already have some initiatives in the field of NCDs, some very interesting, but we are not at scale. And so what do if we pretend to be part of the solution? The solution for us is not only about clinical innovation, so bringing adapted medicine and providing them. Innovation is also about social innovation, about system innovation. And we are very active on that with Access Accelerated. The main idea is to work with local governments, civil society representatives, and some other partners to define what is needed in the field, what are the gaps, what are the needs, of course, and what are the potential solutions, and then to co-build under the leadership of the government, but listening to the voices of the patients, the people living in with NCDs, and Dr. Eva knows that very well because she is a key partner in Kenya. Kenya is one of the focus countries for Access Accelerated, together with Vietnam and Ghana. And so we concentrate on those countries to learn, because it's a lot about testing and learning. And what is unique about Access Accelerated is that really from the inception of the project, we bring the patient voices. We heard during previous workshops and panels that we have to build people-centered healthcare systems and patients in the center, et cetera, et cetera. So very concretely, we do that. And what is very interesting is that for our companies, it's also very clear that we need to listen to the patient for clinical development, which is done now. We try to really better understand how potential solutions will be used. And now also for system innovation, we bring that in the model. So where is Access Accelerated catalytic? Carrie explains that one of the most difficult partnership to put in place, and congrats to you because you had a strong leadership on that with the City Cancer Challenge. Complicated project, and that project needed seed funding to be put in place. So with Access Accelerated, we decided to bring catalytic funds to City Cancer Challenge because we really understand that there is a need for better understanding, bringing evidence on what has to be done, not only on policy shaping, but also in infrastructure creation to improve the situation for cancer care. So that's one of the catalytic dimensions. And another dimension is working with the World Bank. World Bank is another key partner of Access Accelerated. So we go in the countries. World Bank is responsible for bringing data, evidence, and so together bringing with patient voices, we can go for policy shaping. So we inform the debate, and potentially, in some countries, we can help creating that momentum for policy change. And that happened in Paraguay and in Colombia. In Colombia, it's a very interesting example because we've put 1 million to bring different constituencies together, and certainly the people living with NCDs. And through that process, the government decided to change the policy and asked the World Bank for a 200 million loan to put in place the new NCD policy. So that's really, I think, a key catalytic dimension of Access Accelerated. Another element, I think, is that in the beginning on NCDs, the tentative was to fix a problem. So that was a real top-down approach. And now what we want to do, and on that we work with Boston University to better understand what we do also as companies. So Boston University is measuring what companies are driving as projects to understand what are the outcomes and how we create those outcomes. So there is also key learning to bring here. evidence on how we can potentially help changing the system. And from that, I think we can go at scale.
Great. Martin, in many ways, what if I understand, Access Accelerator is also building the roadway towards enabling treatment, unless a lot of these other aspects are put into place, which you're working with in partnership, the treatment can't get there. You mentioned data, and it's been mentioned twice before, the importance of data. Maybe just a little bit to focus in on the importance of that, the data that Access Accelerated is bringing together and how that actually has impact.
Mm-hmm. You don't want to drive blind if you want to go at scale. So there are different ways on building evidence. So, and definitely bringing those data on the table is essential. And so there has been huge work at global level on the policy shaping for NCDs with the UN Declaration on NCDs in 2011, and after that the WHO roadmap and so forth. But there is still huge work to be done at country level, at local level, to get the good epidemiological data to understand how the system works or where are the inefficiencies in the system, and all that has to be documented. And so on that, we work with another partner, a key partner with PATH, and PATH is creating a dashboard to understand what is done and what is not yet done at country level, so to understand what are the different pieces. And what is really interesting there is that if we have, I think, the full picture of what is needed, of what communities and patients would potentially see as solutions, and then you can see where you can fill the gap, that's a way to build on a more systematic and a more sustainable way.
Okay, thank you very much. Martin, I'm going to come over to Katerina, who's the CEO of the Foundation for Innovative and New Diagnostics, FIND, and sometimes refers to the diagnostics as being the forgotten cousin in the access debate, or the Cinderella of access. Katerina, maybe explain that to us and how you see the importance of your organization of diagnostics within this whole debate in the access to treatments.
Thank you. Sure. I mean, every patient's road to healthcare begins with diagnosis. Whether it's a child with fever or, an adult with rapid weight loss or a swollen lymph node, the diagnostic step is key to appropriate and early treatment that, can save many lives. Yet, wherever we look, whether it's for diabetes, whether it's for cancer, whether it's in NTDs or NCDs and infectious diseases, what we see today is that we miss in low middle income countries anywhere between 50% and 70% of patients. These patients get never diagnosed. And so you may wonder, why am I sitting here working on diagnostics where the session is entitled Access to Medicine? But fact is that if we fail to diagnose half of the patients for every disease that exists in this world, that's a major failure in terms of access to medicine. So, FIND drives the development and introduction of diagnostics. And so you asked, what is unique about our model? Well, I think what is unique about our model that it has to be an end-to-end model. So we work all the way from early development to introduction. And we have a model that addresses the specific challenges of diagnostics. Diagnostics generally have much shorter development cycles compared to a drug. Within 5 years, you can have a diagnostic, but their failure rates overall are quite high, and they're quite late. So, from concept to product and product to patients, what we see is that a lot of companies and products fail actually once they are already developed, once they're commercially available. And so our model, bridges the valleys of death across the value chain from concept to patients, with a specific emphasis, though, on late-stage policy change and working with countries to create access models. So we work very closely with WHO as a WHO collaborating center to make sure we define the needs, help define the needs for these diagnostics, and then develop the right diagnostics for low middle income countries. And because the impact of diagnostics depends so strongly on how they're used and which strategy, and they have to be accompanied also by behavior change in countries, we work closely with countries then on demonstrating how to deploy them in local contexts and in local strategies, basically. So, let me just give you a few examples of this. FIND has developed in partnership with industry about 15 diagnostics over the last 5 years across multiple areas. But one such area is in the area of tuberculosis, where, I want to speak about a digital diagnostic approach because it's quite new and that there's a big shift in diagnostics from wet diagnostics to digital diagnostics, where WHO is, as we speak, reviewing the evidence for 4 new artificial intelligence-based solutions that support the interpretation of chest X-rays. And so what we have done there with 13 countries over the last years is build a curated database of chest X-ray images that has enabled WHO to basically rapidly evaluate these new AI-based solutions and allow countries to make a choice going forward in terms of which artificial intelligence-based diagnostics they want to deploy going forward as part of their TB elimination strategies and TB screening strategies. So to make sure that we can flexibly deploy partnership models, in this case, for an AI-based technologies is very important for us. In antimicrobial resistance, for example, we have set up a network with 7 countries that allows us to deploy, as we speak, new fever diagnostic approaches, and for countries to see how can these new fever diagnostics change how antibiotics are prescribed in countries for fever, in an area where we see now, for example, in areas where malaria is decreasing as a health problem, what we see is that 95% of children get antibiotics. So looking at how new fever approaches, new fever diagnostic approaches can make a difference to that, can save lives, many lives of children that actually don't have malaria but have something else, and don't benefit from broad spectrum antibiotics necessarily, it is an area that we're, for example, also looking at. So I could go on and on, but basically I totally agree with what has been said before, is that partnership is about being flexible and being able to work with very different partners along the value chain.
Okay, reminds me of your stew that you were making with all the different ingredients. Clearly the diagnostic element is a very important part of that stew. Just finally, one point, you mentioned to me the other day, diagnostics is data, a lot of data. Can you expand a bit on the data issue? Again, that links up with what Martin was saying, I think.
Absolutely, right. Diagnosis is nothing but data, and oftentimes when you think of sequencing, for example, it's actually big data, data that can be used to inform surveillance in countries and can inform health interventions. However, rarely today that's actually being the case. Even for the most powerful surveillance systems in countries today, diagnostic data are entered once annually, and very sporadically in a data system, and of course are not being used to inform strategies in terms of how to treat patients best, which regimens to deploy, and they're very often coming too late to inform outbreak strategies, right? If you think of the last yellow fever outbreak in Nigeria, that was detected 9 months too late. And so, of course, the action comes too late. So digitalization has, I think, a particular power in the context of diagnostics, because you can digitalize diagnostic information, and there's no reason why we shouldn't have real-time sentinel surveillance in countries that allows us to act fast across diseases, whether it's pandemic preparedness, whether it's AMR. I think, sort of making sure that diagnostics are connected, interconnected to databases, to dashboards that inform us on a daily basis in every moment, I think it's a shame that we've not moved faster on that.
Okay, thank you. Right. You mentioned AMR, which brings me over to Manika. The Global Antibiotic R&D Partnership is one of the most recent, actually, let's say, partnerships that's been established. And of course, we hear a lot about AMR. Manika, can you explain what the key objectives of your model is, how it works, how you see it as unique, and what is the role, particularly with the private sector that you operate with? And of course, you are also bridging innovation and access is an important part of your objectives as well.
So, thank you very much for inviting me here today. And there's quite a lot to say in this subject. In fact, this is my 4th session, so I feel I've already said everything. But I'll try and focus it down to what you've really asked. So there's a lot of challenges in this space. We are, working, when we're talking about antimicrobial resistance, we are really seeing a challenge that's global in nature. It's growing. It's true that it tends to affect the most vulnerable populations. If you look at elderly people, the extremely young population, babies and very young children, immunocompromised patients. But it is something that is happening everywhere. It's happening in high-income countries. It's happening in developing countries. And this is against the backdrop of an increasing problem where we are also seeing huge scientific challenges, and also, I think, also seeing a major problem around funding and lack of incentives. And so increasingly what you are seeing is really a market that's failing, if I can put it that way. It's also important to understand that if you look at the innovation pipeline for new antibiotics, most of this is obviously driven by the private sector, and they're largely happening in small companies, although there are notably a few big companies still involved, still left in this space. But it is a fairly unforgivable space. If in top of the challenges of actually bringing a drug onto the market, there's a whole challenge of how do you sustain access in a responsible way? Because there's obviously the perverse aspect of saying we want to develop new antibiotics or improve the use of existing antibiotics and use them as sparingly as possible. We don't often have the right technologies to do that. Often we're not utilizing those technologies, particularly diagnostics. And often, I think there's a real economic challenge in saying how do we ensure that this can be done in the long-term basis. So against all of that backdrop, we have to try and find a way to make sure that we can get through the scientific challenges. We can go through, I think, this very challenging R&D process. We can not just develop drugs, but develop treatments for multiple different indications. AMR is not one disease, one pathogen. It's multiple different pathogens and many different indications and syndromes. We have to generate the evidence for responsible use. We have to ensure global registration. We have to make sure that we can roll these treatments out in high-burden countries, which could be a rich country, could be a poor country, and we have to ensure that these antibiotics are available sustainably. That's a huge mountain to climb already. Now, this is against the backdrop of, yes, we don't have a big global fund to bankroll all of this. There's relatively limited government funding. Private sector funders are fleeing the space for obvious reasons. And now we are trying to raise the ban of saying this is an important issue, it's going to affect everyone, but somehow I think it will do. I can guarantee all of us that. But somehow I think we're still in a space where the traction has not yet been achieved. So what can we do? And I think this is where I think for the time being, we have to build very creative and innovative partnerships. We have to bring together the private and public sector together. I think the quote that's just in front of me that was shown earlier, our task is not to fix blame for the past, but to fix the course for the future is critical. I personally feel that this is the responsibility of all citizens, but I also feel that there's a huge responsibility of governments. I also think that it's in the interest of the pharmaceutical industry to take action on this issue. There's a lot that the pharmaceutical industry will gain from this, not least withstanding optimizing the lifespan and effectiveness of its other portfolio as well. Now, in terms of the type of partnerships we have to look at, we have to go into this understanding that this is not going to be based on a corporate social responsibility model, largely because even if it's a lot of the innovators are small companies, and even the big companies that are working in this space, we work and know a lot of the people in the big companies, they're not working in the backdrop of flowing cash coming through into their portfolio. Most of these people are desperately trying to justify the continued existence of their portfolios in the companies itself. So we have to really look at a scenario where we can bring in public financing and not-for-profit financing. We have to find a win-win scenario. We have to get a public return on that public investment, but we also have to find a sustainable roadmap for our private sector partner. And that makes us have to think of very different and creative solutions. We have to bring on board and leverage partnerships with a lot of different actors. So any single drug development project is going to involve multiple different actors. We try to find ways to do clinical trials better, faster in high-burden countries. We try different ways to leverage financing and funding from different sectors. And we try to find the way to really look at how we can have a public health impact and look at that sustainable future. So as an organization, we have to start looking at not just the R&D and not just the access, but I would say some increasingly more challenging issues, such as how do we look at procurement models? How can we look at global registration? How can we look at reimbursement models and tie all of these three things together? And I think that, in a way, is something that we have to take on as part of the partnership model. The other thing that I would say is beyond the R&D and access, there are two other types of partnerships we look at. Obviously, one is, I would say, disseminating information, knowledge, and in the AMR community. And so we work with a lot of other partners to hold workshops at conferences and scientific events and webinars and trying to share the scientific knowledge and experience, particularly from the older generation of scientists who've been involved in this field, a lot of them ex-industry scientists. The other aspect of it is that we have to also really play a role to look at creative ways of working. I've mentioned some of the things already, but it means that we offer ourselves as GALP as a way to try very different types of partnerships. And we are very open to working with the private sector and saying, let's think about very creative ways and sustainable ways how we can work together. And so we do see ourselves as a vehicle on where some of these things can be thought of and tried out and tested over the next years to come. Because I think, while I think we can look at what's been done in other areas, we're going to have to think of very different solutions here. And of course, I think, one final aspect I would want to say that is, again, part of the way we think about partnerships is, we recently had an access workshop in July. We brought together partners from actors from many, many different sectors: government, industry, not-for-profits, academia, so on and so forth. And we basically put everybody into a very hot room because it was 35-degree summer day in Geneva, and basically said, well, let's talk about access. Let's break it down into all the different aspects. Okay, let's talk about what are the challenges. Are there potential solutions? And I found it a very creative workshop, not because of some of the ideas that came out that were interesting and it's helped guide our own strategies, but it's actually just to let people share the experience and let that human empathy work to say we're all in a very difficult situation here, right? Please try to see the other's point of view and try to therefore think of solutions with that perspective in mind. And that was something we had as an idea from the outset, because we do feel that there needs to be more dialogue on listening on what the other is saying and thinking about, that course for the future. And so again, I want to put that out there, because partnerships are not just vehicles to go from A to B. They're also a way of helping us thinking about a different way of doing things and understanding what all the different actors bring on the table.
Monica, thanks for that, showing, I think, the complexities of the partnership. But I have to ask you a question, which I was going to ask you. There's this access meeting that you had. What was the conclusion? Did you come out with anything that's going to help anyone in this room?
Well, I think Well, there are two things I'd say. First of all, we did publish a report that's come out this week, so please go to our website and have a look at it. It's not going to be the answer to all the problems, unfortunately. But I think it's given us some idea on how we would move forward as an organization, and also developing a framework for access in the space of AMR, and understanding that there's several touch points that one has to look at. And there's not going to be one solution fits all. And as I've mentioned some of them already. We have to look at, how we think about developing evidence for not just regulatory studies, but public health evidence for use and stewardship. We have to look at global registration strategies. We have to look at in and out licensing strategies and manufacturing standards. We have to look at how we will look at manufacturing and supply with good environmental standards. We have to look at, procurement and reimbursement. And we have, at least for ourselves, developed a framework in which we can work with our public and private sectors partners together, thinking about access. Now, every project we do is going to be different. But if we start thinking of this framework, we can start to apply some common principles, and more importantly, understand certain things we should not forget to do if we want to deliver something at the end. I would still say, though, that my major concern on this area is that we still tend to think of this as a problem that's far away. And one of the things that we have recently done in GARD-P is work with our partner Penta to complete a very large observational study, or finishing a large observational study on neonates, looking at what is happening at ground level in many different countries. And I think the trends that we're seeing are very concerning. And this is certainly, one of the most vulnerable populations, our newborn children, newborn babies. So I think, there's more cause for concern in many respects, because we do see our options being not just very limited, but running out in front of us. And I think that this is why I think we need to have also a call for action, a serious call for action, and really see some concrete actions being taken.
Okay, thank you. Manika, I am aware of the time, and I do want to have an opportunity for you and the audience to engage. Just very quickly, I'm going to spend, if I can, 5 minutes, a little bit more with the panel. Mentioned an access workshop. Carrie, you organised an access workshop, which I had the honour to attend. I don't know if you just want a minute or so on what you felt were the conclusions of that?
So I agree with what you're talking about, getting different groups of people together to discuss this common problem, because certainly in the 10 years I've been in this area, I've seen a movement towards people being prepared to sit in the same room and to put aside maybe some previous held views, to listen and understand if there's some common ground through which we can make a difference. And we've run, I think, 5 public-private dialogues in the last 12, 18 months, including one recently in Kazakhstan. You were on the panel. You weren't just, no, you were there. You were on the panel. You were great, Greg. Fantastic. So what happened at that meeting, which was very interesting, is that we did start about access to medicines. And what happened, because we had such a varied and interesting group of people drawn from the UN system, private sector, civil society, academia, NCDs, as well as cancer, what it did, it took the conversation up to the broader issue about talking about the patient. And the average cancer patient does not just need medicines. They need diagnostics. They need pathology. They need radiotherapy. They need surgery. And if they need surgery, and we have an AMR issue growing in the future, then of course all that good work in trying to treat cancer may well be fold over because of the problems of AMR. So I think the conversation took it up to another level. We realized, I felt, that the group became more aware that in order to solve the problem of cancer treatment and care in the future, we need medicines, absolutely. We need more access, and we need them at a price which is appropriate in that particular country, but they are not going to solve the problem unless we have pathologists in place or technology allowing pathology to take place. We're not going to have it without diagnostics. We're not going to have it without radiotherapy or surgery. So I think that was the conclusion that I felt came from the meeting. It was a broader understanding that when you're addressing a very complicated disease in systems that are either complicated or not in place, you have to pull together all the stakeholders to address, to each of them, as they say, put the patient at the heart of what they're doing, to recognize that they have a part to play for successful outcomes. So that was what I felt came from those sort of meetings.
Okay. Eva, do you have any comments on what you've heard and how it relates to how you kicked off the.
As I sit here and listen about many workshops, many meetings, where we are coming up with call to action, reports, and guidelines and everything, my worry is, and now I'll talk as a civil society advocate, so what are we going to do with all these reports? We leave them in WHO offices, in our Ministry of Health offices. When are we going to implement them? So my take on this is that until we will have these meetings, they are excellent. We all have excellent brains, fantastic points. Until we go back to the people whom we are purporting to help and engage them and see what's the best way. And this is why when we had, through Global NCD Alliance, Access Accelerated, we had in East Africa, the East African NCD Alliance, got to the people living with NCDs, and they came up with their own advocacy agenda. And they had petitions to the parliamentarians, to the senators, to the Council of Governors, to the civil society, to the Ministry of Health, and to the private sector. And they said, this is the way we want you to address our problems. Until we listen to them, we can come up with all the diagnostics in the world. But if you don't get those people to actually understand, you tell them you have cancer of the cervix, stage 4, stage 5, until they become part and parcel of that treatment, we won't have helped them in any way. So I think at this point in time, we need to stop. All of us, we've come up with brilliant ideas. We need to start walking this talk that we are all talking here. We need to move to the people living with NCDs and engage them and start helping them. And I think this is Global NCD Alliance and Access Accelerated. What I have realized is that and I'm not saying this because you work very closely with Kenya, at least you're coming to the point and wanting to know where the problem is, what are the priorities of that particular community, and how do they want to engage. Because we can have beautiful papers, but until we actually engage with the people we are writing these papers about, we'll go home and we'll come back next year for another WHS, or we'll go to Kampala and we'll be talking about the same panel, talking about the same things and what we are doing. And I like what Toko is saying. We cannot say that we'll get over the donations, because the NTDs still require those donations. But at least we engage our government so that we stop or even divert our health funds and give a little bit more to NCDs and NTDs so that we can get the medicines that are so much needed.
Okay, thank you. Yes, I've got to ask each one of you very quickly one comment. So, Manika, do you want to go first, and then before I open it out?
Yeah, I want to respond to that, because I think that we need to be very careful about breaking down the response to very complex issues to just groups that are lobbying for individual diseases. And I think that's something that I've learned over my career in the last 30 years. To give you an example, if you are talking about something like AMR, one of the challenges we have is that this is a fairly nebulous issue. Pretty much, most people in this room would have been treated with an antibiotic, and hence our patient. We have a challenge that has to be dealt with in high-income countries and developing countries, and we need to make sure that we get a good representation of perspectives and views in terms of how to address this problem, because we cannot rely on this being dealt with as a pure charity issue. We cannot rely on this being dealt with as through corporate donations, because the industry just don't even have the resources to supply antibiotics at a donation. So I think we need to be seeing this much more as how we engage, citizens, the average person on the street, into this issue, and to actually feel that they have more ownership on the direction of things like research, and how we think about how, things like antibiotics are actually distributed and used in society. There's no engagement there, so which is the challenge. But I think, we have to start step by step. Our approach has been start with real projects on the ground, but start engaging with multiple different actors and partners, because what we're doing is not so straightforward.
Okay, very quickly, coming up, do you want before we open a final view on what others have said, and I know there's a London Declaration 2 coming up, so that this is a lot that you're preparing for.
Absolutely. I would like to agree on the point about citizen engagement, and I'd also like to agree about what seems to be a disease-based approach, but draw attention to SDG 3 and the global commitment to SDG 3, which is very specific about what we are obligated to deliver on. So I think when you look at SDG 3.3, it's very clear about the ambition of ending the epidemics of AIDS, TB, malaria, and neglected tropical diseases, which is something that has been signed on at a global level. So I think all of us working in global health have an obligation, not just for our own disease areas, but also to make sure that SDG 3 in its entirety is delivered and is met. I, particularly somebody who comes from Zimbabwe, I have a vested interest in seeing that the epidemic of AIDS and TB ends. I also have a vested interest in ensuring that the epidemic of neglected tropical diseases ends under the umbrella of SDG 3. So I think we're all in this together, and we're all working, and each of our programs really work and help to strengthen one another. So that's just what I want to encourage us, that when we think about SDG 3, we really think about all of us working towards that common goal of helping achieve the Sustainable Development Goals, even though our contributions may be specific to a particular area, but we're working for the common good. And yes, thanks, Greg. In terms of the London Declaration 2.0, I mentioned that the commitments that were made by all of the partners was in 2012, linked with the WHO roadmap, which goes up to 2020. WHO has just completed a massive consultative process for a new roadmap, which hopefully will be completed and launched in 2020. And that gives us an opportunity to mobilize additional resources for that roadmap. So we are really putting in and encouraging partners to support and think about these diseases that I just talked about. And my call in this room here, in line with my SDG 3 focus, is that if you happen to be in a meeting and you hear somebody saying, let's work for SDG 3 for AIDS, TB, malaria, and if they stop there, remind them that SDG 3 says, end the epidemic of AIDS, TB, malaria, and neglected tropical diseases. I'm usually the only woman at the back shouting, and NTDs. So hopefully most of you will join me about our collective effort for the individuals and the people that we work towards. And I support what everybody is doing. And I think your success is my success. And I also hope that the success of NTDs will also be your success as well, because that will open up resources for more to be delivered on the NCD agenda. So if we reach the last mile for neglected tropical diseases quicker, what will happen to that resource? It will be there to support all of these other diseases. So I think we're all working towards a common good.
Okay, on that point, I'm going to, please. Marta, Katerina, I apologize. I'm going to open up to the floor because I think it'd be good. So if I could have some gentlemen over here, hands up. I think we're going to get and if, Classic, if you could introduce yourself and your organization. And
excuse me? Hello, I'm Manuel Martin, and I'm policy advisor for the MSF Access campaign. In other discussions on access to medicines, we often hear from industry that there's too much focus on pricing and patents. I would like to note that that certainly wasn't the case on this panel. And my question is, how do you achieve a fair and transparent price of life-saving medicines in PPPs?
okay, thank you. We've got that one. And lady at the top there.
Excuse me. Thank you. Hello, I'm Gaia Giletta, also from MSF. So I think from last year, snake bites are back in the list of neglected tropical disease as a huge problem affecting like more than 100,000 people per year, mostly poor people in rural areas. And since 2016, when Sanofi stopped the production of the very effective antivenom, there has been no transfer of knowledge and no no accessible alternative. So I wanted to know what is being done today to guarantee those people access to this life-saving treatment. Thank you.
Thank you. I'll take one more. Hans, and I'll take the two there very quickly. There's two questions on this side, and then we'll try and answer all of them in one go.
Sorry, again.
This is just, it's very interesting this really is partnership going on here. Yeah, okay, Hans.
Hans Hogezeil, working for Health Action International on a project on access to insulin. I would like to say something about the donations. There was a successful partnerships in many countries for diabetes type 1, and I've seen from very close range the one in Tanzania. And also the transition is now the interesting thing. And the interesting thing in Tanzania is that they probably manage to move the donation program by incorporating the insulin supply now in the national health insurance. That's the way forward, I would say. So I would make this as a contribution to Kenya, because that would be probably the way forward there. My question is now, if you want to continue successfully like that, we have to discuss pricing, because then if you have now a public system through national health insurance, I think we would still be very, very much dependent on what I call intra-country differential pricing, where there would be a special price, like at the generic level, even by the three big companies, on the key insulin products, a special price for public sector, which is replacing the donation, but becoming to a much more a business model. And I would like to have the opinion of the panel on that one. Thank you.
Okay, and the last question then I'll take.
Hello. I'm Laura Henrich. I work for a medtech startup in diagnostics. And I'm interested in the fact, I think partnerships are amazing, but what happens, I think, is they are all pretty long-term. So my question is, how can startups move in an environment that really expects them to be very fast, very flexible, and at the same time address complex issues like the ones we're discussing here today? Thank you.
Okay, I think I've got that one. Okay, so there are a number of questions there around fair pricing. So I think I'll go to our industry representative if you want to make a comment on that. And I know also, Eva, you have some views on this as well from experience on the ground as well, and then I can open it up.
I think that's an interesting perspective to mention that IP and price have not been discussed on this panel, and I wouldn't say that we don't have to discuss it, but I would say finally we have some other things to discuss, which is, I think, as important as price. And you can consider price and the pricing issue if you are certain that you can reach the patients. And in many fields, and we discussed NCDs with Access Accelerated, there is huge things to accomplish before making sure that patients can get the medicine, and then they can afford the medicine. And so if we want to stay on NCDs, of course, there is a question of insulin, the question of some cancer treatment, and I would reject the question of IP because it's not relevant for NCDs. If you consider the essential medicine list, I think that 98% of NCD medicine are off patent. So it's not the real question here. That doesn't mean that there is no question on price, and I would say even a question on cost for the patients, because the real question is, when does a treatment create an impoverishment factor for the patients or for the communities? And that's what we have to take care about. And here again, it's much more complicated than just a price. It's about how you embed that into universal health coverage, how you discuss this cost dimension with health authorities or with other insurers that can operate in the country. And I think that I would agree here with Dr. Hogezeil is that what has to be put in place is systems which would allow tiered pricing intra-country, which is not easy to put in place, because you may want, as a company, make an effort on that, but then how do you make sure that this access scheme which is put in place benefits to the patients. And there is many difficult experiences on that front, which shows that the effort which you make is just lost in transaction. So that along the distribution chain, you have new markups that in the end totally erase the effort you make in the beginning of the chain. So that's why if you want to put those things in place, you have to discuss that with the government, you have to discuss that with the actors of the distribution chain, and then in the end with the healthcare professionals. So indeed, pharma industry is responsible for that, as with many others. And what I would like to see happening is a fair discussion on how to put those systems in place. And I think that here MSF campaign could help also, because you have experience in the field through MSF. And definitely I think we should, instead of throwing the ball like that, create a new environment within which we could discuss those questions.
Okay, if I move over to Eva, because you've been quite vocal also about certain issues about affordability, but again, it's on the markups. And in Kenya, there's a lot of issues. Huh?
Yeah, I want to agree with the person from the audience that about the systems getting, the government taking up that. Kenya is already doing exactly what Tanzania is doing when it comes to insulin. And there's been a system to reduce the cost or an obvious activity from the Novo Nordisk and the Ministry of Health, reducing the cost of Mixtard. That's the commonest insulin being used now by people, our type 1 diabetes. That insulin for children, the projects that have been going on, I think they was the same in Tanzania. It's not coming to an end. But I think because the government got involved, this will continue and it will be sustainable. The thing is, what we try and tell our people with the type 1 diabetes, the parents, there's nothing for free. And even that insulin that these kids get free, it's not free. Somebody has paid for it. And this is why the government has to subsidize now the cost of insulin so that it will be affordable even after the project goes. And this is the thing. The idea is to try and make sure this will happen for most of the other NCD disease medications because they are lifetime. So we are trying, that's what as a society we are trying to fight for, not just for the one, not just for the insulin. We're going on for medications for epilepsy, medication for other cardiovascular diseases that are critical for sustaining life. So ideally, what we hope, and I know it's going to happen, we are engaging the Parliamentary Health Committee, the people who will help us pass these bills into law. Once they get to know, and we write these papers, concept papers, and we have right now we have a very, I would say, supportive Parliamentary Health Committee that listens. And this is why we have a member of that committee coming to see what's going on and listening to this kind of conversations. Because when she goes back, I'm sure she will be able to tell the other members of the parliament, when this bill comes, whether it's about pricing on medications even for NTDs, for NCDs, I think people will be sensitive. And the government is going to look at it such that we are able to sustain the affordability. The markup, now that's something that has been, there's been, we have a system in Kenya, the Pharmacy and Poisons Board, that registers and regulates the cost, or rather the drugs coming to the country. Now, I think Kenya has one of the most free markets when it comes to pricing. The system, the pharma, Sanofi, Martin, you support me here. Sanofi brings a type of insulin called Lantus. The cost of Lantus, if I get it from Sanofi directly, is half of what I'll get it from one of the private hospitals. In fact, maybe a third of what I'll get into from other pharmacies. Because we have distributors, we have by the time it gets to the supplying pharmacy, it's been marked up by more than 200%. We have drugs being marked up by 200%. Yet the allowed markup by the government is 33% from
the source up to by the time it gets to the patient. But the control now, this is where we are hoping that with the kind of creating awareness, letting the government know where the prices have really skyrocketed in the private hospitals, we are getting now the Ministry of Health paying attention to the information. And some of these things will come by people from the civil society, patients groups, talking about, I went to this hospital and the insulin, which is supposed to be 400 shillings, is 3 times. So the minute that gets now to the Ministry of Health, we have inspectors and we have people, the law is able to catch up with these people who are already marking up. So I have a feeling with time, it's a challenge and it's not easy, but with time, we are going to be able to accomplish that.
Okay, thank you. I've got a very small amount of time left. I'd just like to, any comments from Carrie? General comments on any of the questions, and then we'll...
Yeah, I hope that people understand that pricing of all medicines is an issue because we would like them to be cheaper. I don't think there's anyone putting their hand up saying, can they be more expensive, please? So it is an issue across all aspects of medicines and in cancer specifically. What I will say, though, is that the focus for certainly my organization and many of the organizations I represent in many countries is just simply the availability of the essential medicines list. As mentioned, most of it's generic. And within that list, there are things called opioids and morphine. And the majority of countries around the world where cancer treatment and care, because there's no surgery, skill sets, pathology, radiotherapy, or the drugs available, they don't even have access to morphine and opioids to allow someone to die, with some dignity. So this is a broader issue beyond just the pricing of drugs, I think. I think we need to look at now how over time we can convince governments to invest in the appropriate health systems and infrastructure to make sure that the right drug, the right treatment gets to the right person at the right time, which is why the recent World Cancer Leaders Summit was pivoted completely around universal health coverage. Because we totally believe as a cancer community that that is the way ahead, not just for the cancer community, the NCD community, and also the NTD community. Those core investments in health systems infrastructure will allow us to treat any patient, whatever they have. And as we know, the older we get, and I count myself as one of the older population, I have comorbidities. I will probably have diabetes. I already have blood pressure. I have arthritis, and I may well have cancer. So all of those individual diseases come together with aging, and that's where the health system has to respond with a complete set of available treatment protocols.
Thank you. Toko, any final?
No, I think that's really well and nicely covered, and I'm sure throughout some of the conversations next door, some of these conversations around the systems, the role of universal health coverage, what's covered under UHC in terms of the essential health benefit package, questions around equity, doing the most for the vulnerable populations, because this is really what we're talking about in terms of access. Here we're talking about access from the point of view of product development and cost, but actually when you think about that poor individual then having access to that medication and putting it in their mouth and having improved health. That's also another big part of it that we need to talk about when we're thinking about access. It's such a wide spectrum of things that we think about. So I thank you to my fellow panelists for that very nice conversation.
Then I'm going to give the final word to our forgotten cousin, as you are, Cinderella. So you're not forgotten. And a final comment then from your side of the access to issue.
Well, I think with UHC we have a unique opportunity to strengthen primary health care settings that are really key to reach patients that we've previously not reached and to engage communities differently. And diagnosis is a key part to primary health care settings. So if we achieve insurance coverage of essential diagnostics, I think that will go a long way to stimulate and meet demand. And so what I wish for is an innovation chain that basically addresses and works against concrete patient demand, and that we can close that demand supply chain going forward. I think really, as has been said, universal health coverage and working together as a community against that, we have an opportunity in that we've not had before in addressing access challenges and also affordability challenges, right? Because it offers a new stakeholder dimension that has not been there before. And last word on innovation. Yes, the innovation very often comes from small startups, right? The transformational innovation. And it takes a lot of patience. And clearly today, the pathway from a discovery to patient impact is way too long. There are co-investment schemes that help along the way for innovators, but clearly we have to work all together, you know, to help innovators to actually get their products to where it's needed faster.
Okay, thank you very much. And we're just only 4 minutes over time, so I'd like to thank all our panelists for their contributions in the traditional way from me. And thank you for your attention and your questions.